Hello, everyone, and welcome to our second webinar in the COVID-19 Safe Hospital webinar series, Managing Pandemic Risk in Health Facilities. This is the continuation of our lessons from the COVID-19 pandemic series that we started in 2020. My name is Ana Cristina Torlund, and I am a program officer in the UNDRR Office for Northeast Asia and Global Education Training Institute here in the Republic of Korea. I will be moderating this webinar today. Before we start, I would like to make a note that all attendees are mute by default. If you have a question that you would like to ask any of the panelists, please submit in the chat box. At the end of the panelist presentation, I will select a few questions and I will direct them to the panelists. Since we started this webinar series last year, we have conducted already a dozen of webinars, including the one last month, promoting global, regional, and national advocacy for COVID-19 disaster risk reduction across all sectors. And we have started the COVID-19 Safe Hospital webinar series, strongly advocating for multi-sectoral coordination for COVID-19 preparedness, readiness, response, and recovery, guided by the All Hazards, Health Emergency, and Disaster Risk Management Framework and the Sendai Framework for Disaster Risk Reduction 2015-2030. However, the wide-reaching health and socioeconomic impacts of the COVID-19 pandemic are far from over. Thus, there is a need to continue and further strengthen our bonds, sharing our experiences, lessons learned, and guidance tools for leading with the pandemic. We will move on our second webinar, recognizing that hospitals and other healthcare facilities, such as long-term care facilities, play a critical role in controlling the pandemic by slowing down COVID-19 transmission and reducing death associated with it. The second webinar takes into account the role of hospitals as part of a national strategic plan for emergencies and disasters from all hazards. Let's move now to the opening remarks. And it is a pleasure to welcome our first speaker for the opening remarks. I'm honoring to present Mr. Altaf Musani, Director of the Health Emergency Interventions, WHO Health Emergency Program at WHO headquarters. Mr. Musani, you have the floor.
Thank you, Anna, and good morning, good afternoon, and good evening to everyone. This seems to be the new normal. I'd like to also extend my greetings to the distinguished panel of speakers, but equally important, all of you from attending this very important webinar series from all over the world. I too am very pleased to welcome you in particular to this second webinar of COVID-19 Safe Hospital webinar series. And as Anna said, there is more to come. Starting off, I'd like to appreciate and offer my thanks to the United Nations Office for Disaster Risk Reduction, the International Hospital Federation, and of course, my WHO colleagues who have organized this timely webinar series to further support hospitals and hospital work across the world as they scale up capacities to manage the current pandemic of COVID-19, but also look forward in terms of future risks and threats. This challenge upon us has been also echoed in the virtual 73rd World Health Assembly, where 2021 has been designated the International Year of Healthcare and Healthcare Workers. Roughly mentioned by Anna, myself, I am currently the Director of Emergencies in Geneva, but before I came to Geneva, I've spent more than 2 decades working in challenging environments where my team and myself had one common goal in mind: save lives. But a colleague on this call often reminds me that during this tenure, we have obviously that raison d'etre to save lives, to protect lives, but also look forward and think backwards in terms of lessons, best practices that really enable us to protect and build systems for tomorrow's risks and threats, and eventually avert some of the mortality and morbidity based on some of the practices and lessons that we've learned. The pandemic has taught us so many hard lessons, but the old-time lesson is we must prepare. More specifically, we must protect and defend the vital and critical infrastructure that enables us to save lives. As I look back upon my recent experiences, particularly in Iraq and Yemen, I just would like to share with you that I was reminded that just a couple of years ago, millions of people in Mosul were surviving and eventually fleeing heavy bombardment and heavy fighting. It was the availability of trauma care, including triage, which saved countless lives. It was WHO and its partners that brought this healthcare to the front lines of Mosul. This was made possible by the establishment of field hospitals that provided trauma as well as other medical care as close as possible to very risky areas. This was not a new system, but an extension of existing systems that was created through referral care across front lines, and it was an important system that people needed to protect from the heavy bombardment. Similarly, and most recently, as I worked in Yemen, I was challenged with a healthcare system that, due to chronicity of conflict, more than 50% of the entire health system, hospitals, healthcare centers, and healthcare workers were non-functional. Here again, the United Nations, particularly the support of WHO, UNICEF, the World Bank, and its health partners in coordination with health authorities, scaled up a support to revitalize health units, health centers, and equally important hospitals so that way people can seek health care in a very conflict-ridden environment. This vitalization investment was the backbone of Yemen's response to COVID-19 and continues to respond to other risks and threats as the people face in Yemen. Hospitals and healthcare workers and their support staff make hospitals operate in this global pandemic, and they've been championed as heroes. I would like to echo my appreciation for their deep and long dedication to serve people, but reminding you that healthcare workers and hospitals have always played that central role, always been critical assets in health emergencies and disaster risk management during and before and well after pandemics. Hospitals are not only providers of clinical services for treatment, but also are integral in promoting well-being and disaster risk reduction within the premises and its immediate catchment area when the need is at first. In fact, many of the suppression and mitigation measures that we have been talked about, such as curfews, lockdowns, and closures, not only slowed the transmission of the virus, but equally protected the health system from being overwhelmed. Hospitals continue and will remain a part of national strategic planning, policies for emergency and disaster risk management, and it further ensures that providing provision of all sorts and resource allocation and an all-government approach will make sure that these hospitals and its staff and its services stay functional and operational throughout pandemics, but also outside of pandemics. In that view, we've invited an esteemed group of experts from different parts of the world to share their experiences and their ideas within hospitals, but also within the health system. We've also invited our WHO colleagues to present a suite of health facility assessment tools that were developed by WHO to support the countries based on practices that many of you represent. And rest assured, we are carefully documenting the discussion here today, as well as within the webinar series, to help capture your solutions, your ideas, that we can safely and quickly transform these ideas into actions and build them into national policies, as well as future strategies to make our countries resilient to all emergencies, disasters, as well as the pandemic. I wish you a useful, fruitful, safe hospital webinar. Please stay safe, stay healthy, and thank you. Back to you, Anna.
Thank you, Mr. Monsani. Now the opening remarks from UNDRR, and I am pleased to invite Ms. Paola Albrito, Chief of Branch Intergovernmental Process and Office for Disaster Risk Reduction, to take the floor. Ms. Paola Albrito, the floor is yours.
Thank you very much, Ana Cristina. Ladies and gentlemen, distinguished speakers and colleagues, it is really a pleasure to be with you today for this important event on safer hospitals. This has been organized jointly by the United Nations Office for Disaster Risk Reduction, WHO, and the International Hospital Federation. The partnership in organizing this webinar series has indeed been rich and fruitful. It is also a pleasure for me to take the floor after Altaf and the richness of his experience in the field. Safeguarding hospitals by applied disaster risk reduction actions in the face of a wide range of hazards, including pandemics, means saving lives and ensuring sustainability of our communities. In the last year, COVID-19 has uncovered multiple vulnerabilities in our healthcare infrastructure. COVID-19 has also demonstrated weaknesses in our ability to tackle systemic risk that cut across multiple sectors, as well as multiple health risks at once. This has been, for example, the evident case in the predicted double challenges of fighting malaria and COVID-19, potentially impacting some of the most vulnerable countries. Responding to the call made by the Sendai Framework for Disaster Risk Reduction, governments have committed to develop national and local disaster risk reduction strategies, building on a multi-hazard approach. This represents a solid step, allowing to assess and plan towards the safety and functioning of our key infrastructure. Making health infrastructure safe in emergency is a critical part of this. And safe hospitals are also fundamental to achieve progress towards multiple Sustainable Development Goals, including Sustainable Development Goals 3 on health, and 9 on infrastructure. A recent review undertaken by UNDRR showed that most national disaster risk reduction strategies give limited attention to the management of biological hazards and emergency and focus largely on natural hazards. And also, most preparedness and response plans are designed for natural, localized, and short-term events. COVID-19 again has demonstrated the limitation of such plans, though its prolonged nature and its wide geographical spread. It also highlighted that the development of a national strategy for disaster risk reduction that includes multi-hazard risk management is the only way forward. As an example, Somalia during 2020 was hit hard by a triple threat disasters that included biological hazards of COVID-19 in a fragile health system, a locust plague affecting the food production, and flooding, oversaturating and damaging critical infrastructure such as healthcare facilities. With the alarm bell raised by it now, it is more important than ever to ensure that we can protect hospitals and other critical infrastructure against disaster risk. So practically, what should we do? We very much look forward to hear from you and the distinguished panelists. At my end, I can share a couple of considerations. First of all, we need to step up the integration of biological hazards, such as pandemic, as well as a wider range of hazards into national disaster risk reduction strategies in order to address disaster risk through a more systemic risk lens. The systemic engagement of health sector in the planning and development of the strategies needs to be ensured. In this core, the UNDRR is working with WHO to develop a supplemental guidance to integrate this important work. Second, we need to integrate disaster risk management into healthcare provision at all levels. We certainly need to learn from current situation and increase the investments in prevention. Health emergency strategies and preparedness plans need to be aligned with disaster risk management plans. And we need to ensure that investments are going to be risk-informed. Strengthen national regulations that governs design and maintenance of health infrastructure, but also build the knowledge and capacity of frontline workers and health responders. The Bangkok principles on the implementation of the health aspect of the Sendai framework and WHO's health emergency and disaster risk management framework provide a strong foundation on how to reduce health risk and ensure disaster risk is integrated into health sector. Finally, I wish to stress UNDRR support to WHO's Safe Hospital initiative that aims to making health facilities safe in emergencies and share their vision to protect the life and health of people from emergencies and disasters. Safe hospital can only be designed and built if there is a risk-informed national plan in place. This is all on my end, and I would like to hear very much on the elements that are emerging during this webinar and the discussion. And now I leave you in the capable moderation hands of Anna Cristina.
Thank you, Ms. Paola Albrito, and thank you both for your inspiring words and for setting the tone of this webinar. Thank you very much. Now, let's welcome our 5 panelists for the second webinar, and you will see the bio slide in front of the screen. I would like to start the panel discussion with the first presentation, will be on the experience from Nepal. We are honored to have both Ministry of Health and WHO speakers from Nepal. It is my honor to invite the WHO representative of Nepal, Dr. Rajesh Pandav, for a brief overview that will be followed by Dr. Samir Adhikari, Senior Health Administrator and Chief of Health Emergency Operations Center at the Ministry of Health and Population at the Government of Nepal. Dr. Pandav, the floor is yours, followed by Dr. Samir Adhikari.
Okay. Thank you, Anna, and good evening from Nepal. Good morning, good afternoon to colleagues in different time zones. So Nepal has a high risk for many hazards due to its geoecology. It is ranked 4th in terms of climate change related risk, 11th in terms of earthquake, and 13th in terms of seasonal floods. Other major hazards that lead to emergencies in Nepal are landslides, avalanches, glacial lake outburst floods, droughts in hilly districts, and epidemics. Hence, Nepal ranks as one of the top 20 countries with multi-hazard risk. Cognizant of these risks and learning from the experience of major emergencies faced, Nepal has continually updated its disaster management policies and governance structures to enable harmonized contributions from different sectors and development partners as part of the implementation of global frameworks such as Sendai, international health regulations, etc. There have been notable developments in the health sector disaster risk management interventions. The National Health Emergency Operations Center was established in March 2014 at the Ministry of Health and Population. The hub and satellite hospital networks were designated prior to that, both of which became highly relevant in the response to the Nepal earthquake in 2015. Based on this experience, provincial health emergency operations centers have been established between 2017 and 20 during also the COVID-19, and a dedicated health emergency and disaster management unit working directly under the Secretary of Ministry of Health and Population was formed in 2019. All these interventions have been implemented in partnership and with the support of WHO, with resources mobilized from many development partners. So given the high hazard and vulnerability profile of the country, it is not sufficient for the hospital sector to be strengthened to provide quality services with high coverage. The hospital sector also needs to be resilient to multi-hazard emergencies and disasters to be able to withstand and have the surge capacity to continue to provide life and limb-saving emergency medical services and continuing to deliver essential health services during times of high demand. This emergency disaster resilience has to be deliberately strategized and built as part of the health system strengthening, synergized with national health security enhancement interventions. The development disaster risk reduction nexus should be fully appreciated and utilized to enable a health system and especially a hospital sector that is strong, sustainable, and resilient. With this perspective, WHO has been continuously extending its support to the Ministry of Health and Population and all health sector partners to mitigate the impacts of emergencies and disasters on the hospital sector, enhance preparedness and response readiness, and ensure a coordinated response to multi-hazard emergencies that occur in the country. They also enhance intra and intersectoral coordination through the network of health emergency operations centers and facilitating effective functioning of the health cluster. Deploying field teams in all provinces to support health emergency operations centers to facilitate interventions across the disaster management cycle, piloting and scaling up of hospital safety assessment and strengthening initiatives that address structural, non-structural, and functional components of safety, including through establishment of emergency medical logistics warehouses with stockpile at 10 of the 25 hub and satellite hospital networks, and also to enable the essential and critical linkages between pre-hospital, hospital, and post-hospital rehabilitation care services for emergency through various mechanisms, including the emergency medical deployment teams and telemedicine initiatives. Also, to enable systems and capacities to manage the surge in demand of mental health, RMNCH, and sexual health and gender-based violence prevention services, to address NCD, also to address NCD and chronic diseases, strengthen capacity for investigation of disease outbreaks to rapid response team and hospital-based clinical teams for infectious hazard management. Also to support expansion of quality assured laboratory services and overall capacity for information management and decision support. With this, Dr. Samir, the Chief of HADMU, will highlight some of the key interventions in a more detail in his presentation. Over.
Thank you, Dr. Rajesh. Thank you, Anna. Good morning, good afternoon, good evening to all. As mentioned, I am here to share the role of hospitals in the multi-hazard strategic plan for emergencies and disasters in Nepal, along with the health emergency centers roles. Charlie, do you? Sorry. Yes, thank you. Next, please. Next slide. Nepal is vulnerable to many natural hazards, as mentioned by Dr. Rajesh. Despite regular seasonal flood, landslide, road traffic accidents, we experienced massive earthquake in 2015. This led us to multi-sectoral disaster risk reduction interventions through a consortium approach, and health sector preparedness was emphasized with hospital safety as a key pillar. Ministry of Health and Population then implemented key health sector disaster risk reduction interventions with support from WHO. Major interventions at that time was designation of area-specific hub and satellite hospitals, network across the country with in Kathmandu Valley to cover the capital city, establishment of health sector emergency operations centers with special focus on coordination with the hub satellite network and between the networks. Next, please. From the experience of response to Nepal earthquake, the identified needs for enhanced hospital responses were standardized assessment. These were done for structural safety, establishment of emergency, medical logistics, warehouses, creation and maintenance of systematic linkages between the pre-hospital care, post-hospital care, rehabilitation components also. Comprehensive hospital emergency, disaster preparedness and response plans, as well as communications and referral plans. Development and endorsement of different SOPs, guidelines for coordination and response. Capacity building through standardized training, including simulation exercise to orient on and update plans. Coordination and response. Through these preparedness and readiness efforts, Nepal has adequately planned for effective response. Next. We concentrated our work on structural, non-structural, and functional assessment in 10 out of 25 hub satellite networks. The Hospital Safety Index Plus application and evidence-based guidance was piloted and standardized for national use. Linkages between essential healthcare services and continuity of emergency care components were established through different techniques. Next, please. Though hospital disaster preparedness and response plan was effective in management of mass casualties incidents, the outbreak of seasonal flu, dengue, scrub, typhus, foodborne diseases, and other could not be addressed using the same plan. Thus, specific contingency plan for infectious hazards management modeled after influenza preparedness was developed and incorporated to tackle emergencies in infectious origin. Later, infectious hazard management was also tested. National training and management manuals were designed and capacity development activities were conducted in hub and satellite networks. We did not want to leave any gaps unfilled. We don't want to leave any person behind. Next. Now, during COVID-19 pandemic situation, rapid adaptation of hospital disaster preparedness and response plan and infectious hazard management was done by a leading hub hospital, the Patan Academy of Health Sciences in the Kathmandu Valley, which was further rolled out to other hub and satellite hospitals under facilitation of Health Emergency Operations Center and WHO country office. Different hospitals were initially designated as COVID-19 level 1, 2, and 3 hospitals based on their IPC, critical care resources, and capacities to manage COVID-19 cases. Number of hospitals designated solely to manage COVID-19 cases were increased during the high case load Designated hospitals for COVID-19 were supported with additional infrastructure, equipment, supplies, medicines, staffing, technologies, trainings, networking, and funds. Routine essential healthcare services were continued throughout the country with application of adequate public health and social measures. We did not let COVID-19 stop the delivery of essential services. Next. In order to strengthen the capacity of hub and satellite hospitals, Health Emergency Operations Center led to facilitate and coordinate these services and rapid assessment of all COVID level 2 hospitals on IPC, clinical preparedness, water and sanitation and hygiene, healthcare waste management was conducted and regular required trainings were provided. Furthermore, different pocket guides were developed as our peripheral brain companion, easily available to guide our work. Assessment of oxygen demand was done. COVID-19 labs were quality assured. Hospital information management was strengthened. Psychosocial support was provided with support of different technologies. Different health kits were supplied. Emergency medical deployment teams were identified, prepared, trained, and deployed. Deployment kits were provided to them. Much recently, healthcare workers were also administered with COVID-19 vaccine as frontline workers in first priority. Next. These are some of the major SOPs and protocols issued for COVID-19 management and COVID and non-COVID healthcare services continuity at hospitals. Therefore, Nepal acted on both COVID and non-COVID health issues. Next. Health Emergency Operations Center have been playing a major role in designating hub hospital or hospital networks, making their functional linkages, enhancing their capacities, supporting logistics, linking hospital incident command systems and hospital disaster preparedness and response plan to districts, provincial incident command system, and contingency plans during the different disasters. Similarly, 7 sub-national health emergency centers have coordinated in their designated administrative area for development of different protocols, different guidelines, and disseminations of different messages and different guidelines also. Hospital preparedness, training, logistics, and risk communications as well. Coordination was also continued during COVID-19 as needs of hub hospitals and COVID designated hospitals were identified through regular meeting with hub designated hospitals and provincial health authorities. Coordination was an important work to do to bring things together and have synergy. Next. The figure provides daily updates of health sector response to COVID-19. Till now, nearly 500,000 people have been vaccinated for COVID. The first priority group for vaccination were health workers. There is no question or doubt about vaccinating the health frontliners first. Next. The previous well-operated centralized health network was not existed after federalizations. New structure was not well enough matured to operate properly, so gaps and challenges faced were critically related to coordination among 3 tiers of governments and inadequate preparedness, readiness, and response to COVID-19 from hub satellite network and COVID designated hospitals happened. These were delay and non-activation of hospital ICS after emergency declarations, no contingency plan for infection management, hub and satellite hospital networks, wide resource not adequately mapped and utilized, suboptimal IPC capacity at most hospitals, lack of effective hospital information management system, delay in implementation of technologies like telemedicine services, emergency medical deployment teams, etc. Next one. Ministry of Health and Population has planned to dedicate itself to strengthen hospital response during disaster and emergency through Health Emergency Operations Center with activities, different activities identified. These are disaster risk reductions, enhancing mitigation interventions and disaster risk management, updating plans and SOPs, standardizing training, conducting periodic simulation exercise to test the systems, strengthening and capacitating hospitals and emergency and healthcare system combination. using technology and dedicated web portal for hospital information management and expansion of hospital safety index plus applications at all key hospitals. In summary, I would like to end by saying that a whole of government and whole of society action is needed for building, maintaining, and sustaining safe hospitals. Thank you. Over to you, Anna.
Thank you to our two first speakers. And I would like just to brief recap because of time. Dr. Rajesh Panda, thank you for sharing the hospital safety needs to be resilient to continue delivering for all population quality services. You highlighted very well the DRR and the health nexus. And thank you, Dr. Adhikari, for sharing with us your challenges, gaps, and very good recommendations way forward that I think all participants will look carefully. And I was impressed of the amount of vaccination you have in your country. So thank you to both the speakers. And let me introduce our next speaker, Dr. Carlos Alves. Dr. Carlos Alves is the senior specialist in infectiology of the Hospital Center of São João in Portugal. Dr. Alves, you have 8 minutes. Over to you.
Thank you, Anna, and thank you all. It's an honor to be here today and speaking of the experience that we had in our hospital and in part of the experience of Portugal. So if I could have my first slide. Sorry, this is the last one. Next, please. Okay, so just to let you into the context of our hospital in Portugal. So this is my hospital where I work, and this was a hospital that was built in 1959, so it's getting old. And it's a 1,000 bed hospital with all major specialties, including neurosurgery, cardiosurgery, and also in intensive care, things like extracorporeal membrane oxygenation, for example. We are the reference center for a lot of people in the north and in some circumstances for all the north region of Portugal. Next, please. As I was saying, so this makes a hospital that provides care for about 300,000 people in the direct area of action, and in between 2 or 3 million of people that are in the north of Portugal. And for some specialties, we are the reference hospital. For example, as for emergencies or for emergent infectious diseases like Ebola, or if we have any cases, we are the reference center for all of the north and center of Portugal. So before the pandemic, we were already one of the reference hospitals in Portugal for the first cases of COVID-19. This had an implication because during the first months of the pandemic, so between January and February, we were receiving all suspect cases of the north of Portugal. Next, please. This is the same picture, but today, just to let you know how the entire area has grown in buildings and so in population also. Next, please. We are a center, so a hospital center. We have 2 hospitals. One, the major building, the major hospital is São João, which has about 700, 800 beds. And then there is a smaller hospital, which is mainly for chronic and some psychiatric patients, the Valongo Center. We have about 6,000 professionals working, mainly, of course, nurses, but also a lot of nursing assistants and doctors and a lot of trainees. Next, please. Well, in Portugal, the pandemics went, as this picture will show you, with 3 major waves. So we are now finally leaving the 3rd wave of COVID-19. And if the difference in size looks very important, it is also very important to look at the first wave, because as for the north of Portugal and particularly São João Hospital, this was very disproportionate between us and other areas and other hospitals. So the beginning of the pandemic happened in the north of Portugal, and particularly our hospital was the first to receive cases. And when we were receiving the first cases and during the first part of the first wave of the pandemic, only our hospital and 2 or 3 more were receiving patients. So many hospitals were not prepared to receive any patients. So this meant that during the first wave, we had a huge demand for our beds, for our facilities, which we could not see if we look at this line just as it is. Next, please. So how did we cope with this situation throughout the entire pandemic? Next, please. So during the first wave, although we had been planning for such as an emergency as this would be happening, the fact is that no one was really anticipating the amount of patients that we would have to be dealing with in such a small period of time. So this was a major challenge for us. We were adapting and we had to improvise a lot based on plans that were being built at the same time, guidelines from the national authorities that were being prepared, including with the expertise of many of people that were working already in the field, including from our hospital. So we were building the structure and building the guidelines at the same time that we were introducing them and working with those guidelines that we were building, that we were making. So major challenges were facilities. So we had to change rooms and wards into COVID areas, preparing all the spaces with the donning and doffing areas, major works in engineering, creating sub-pressure rooms all over the hospital in the different areas that were being prepared to receive the increasing amount of patients. At the same time, we had to prepare human resources. So the first human resources, the first professionals that were used were the ones that already had been trained, for example, as the people that could be managing cases of suspected Ebola, for example, before the COVID-19 pandemic. And then we were training in cascade. So people that had already some training would be going to a new area where it would be open a new COVID area and train the people that were coming to work there. So like a tree with different branches through our hospital, we were converting and creating new spaces, new COVID areas with this branching of human resources and facilities. Patient flows was a major headache for us because we were working as one of the biggest hospitals in the north of Portugal, receiving all kinds of emergencies and having to support all kinds of treatment for people without COVID-19 at the same time as this huge amount of patients were coming for COVID or suspected COVID. So this meant that we were designing new patient flows through the emergency room, through the different inpatient areas, through the ICU, and creating different areas and different path flows for all these patients. And well, and the rest is that we had to improvise a lot. We managed difficulties that were not foreseen. For example, in the case of PPE, we were receiving different PPE from donors, from the National Reserve, also trying to acquire whatever we could. But as we all know, this was during March and April. It was a time of a very difficult access to these PPE equipment. And sometimes the problem was even worse because we were receiving different kinds of PPE that we did not know, or we could not be sure that it had the quality that was needed. So this was one of the problems that we had. Next, please. Between waves, so during summer, as a rule, we had as we could see, we had a decrease in the number of cases. We had an opening to plan better what we could expect would happen in the autumn and winter. And so we had a review of our planning, of our contingency plan. Next, please. And this is a plan that was meant to be, and it is a general and strategic plan, so that it will have to have different guidelines supporting it with more specific and operational procedures. It is based on all the knowledge that we have acquired and also in our experience, particularly from the first wave, and in the guidelines from the National Directorate of General Health. So we use this kind of hierarchy of guidance. So we always follow the national guidelines, and we have local guidelines for specific or operational areas, and sometimes they are in fact a little bit ahead of some of the national guidelines. And this is something that happens because national guidelines are reviewed sometimes with a very long time, because they have to be prepared for all sorts of hospitals and institutions, and sometimes we have to move a little bit, but we are working together with the Portuguese Director General for Health, and so we are comfortable with what we are implementing, and also based on the best practice of already existing experience, for example, technical recommendations in terms of infection prevention and control, and following, of course, the expertise of the local managers and leadership in the different departments. Next, please. So I would like to stress the idea that we have a plan that has different levels of activation. This is very important because we have to keep the hospital running, but at the same time be prepared to move ahead, to be prepared for the next stage where more people and more patients would be coming. So we divided the plan into different levels of activation that would be put in place as soon as the number of patients would be increasing, or the number of patients that we could foresee through the epidemics, the evolution of the epidemics would advise. Next, please. This was very important because in this way, as the epidemics was evolving and people were coming to hospital, we were already one step ahead in the preparedness of the areas and the human resources to face that incoming flow of patients. For example, in the emergency room, we had different areas that were not being used in the times when less patients were coming. For example, this tent that you can see, and wood and other provisional facilities that would only be activated, would be only put in place as soon as we felt that the number of admissions was going up. And this was already in the plan, so it was prepared. So, for example, in the right side, you can see the number of doctors and nurses that we had to be prepared to be able to be working in the different areas as far as the epidemics would go, and as far as we would be opening new areas for attendance. Next, please. Another example, this is for the ICU. So the beds that were prepared for COVID and non-COVID patients, and also for ECMO, so extracorporeal membrane oxygenation. And as you can see, as the level of activation went up, we would have more active areas with beds just for COVID patients. And if the level of activation decreases, we will release those beds and put them back to work with non-COVID patients. Next, please. So what happened? Sorry?
We are beyond time, if you can wrap up.
Okay, so just very quickly what happened. So in the emergency department, we saw a decrease in the number of pediatric children that came to the emergency department, but during the year, the number of patients in the adult areas kept very high, and with the peaks of the COVID waves. Next, please. In the acute care, just to let you know that the major difference that we had in the terms of our occupancy is that we used a lot of beds that were meant for ICU, and we had to increase almost double the amount of beds with available for level 3 ICU. Next, please. This is how the things went on along the year. So as you can see, the number of beds in blue was always being a little bit ahead of the number of patients that we had. So we had, of course, days in which we were we had a lot of difficulties in allocating patients, but during the most of the time we always had a little reserve, and in fact we used it, and we were giving assistance to hospitals from the north and also from the south of Portugal. We received patients from Lisbon and from many hospitals in the north of Portugal when they were also in difficulties. Next, please. Going to the patient's needs outside of COVID, this is a major difference that we had to have during the first wave, particularly during the first wave, having patients coming to the hospital for outpatient appointments. This was, first, it was difficult because of the risk for them and for many of our patients. And second, because patients were clearly not wanting to come to the hospital. One of the solutions was really increasing the number of phone appointments and video conferencing with patients. And as you can see, during the months of March and April and May, this was a very important area. Later on, we also improved our capacity to answer to the patient's needs with increasing the number of hours available for the patients to come to outpatient clinics, and so avoiding a lot of people in the same place, increasing the number of waiting rooms, having all facilities prepared to receive the same number of patients, but throughout an open, a larger timetable. Next, please. Also, other needs were for surgical procedures, and we had to increase the surgical activity during summer between waves in order to be able to recover some of the patients that were, well, delayed through the first wave, and preparing ourselves for the second wave to be able to decrease the least possible the number of scheduled procedures, which we had in fact to do already in January. But even though with this, at the end of the 2020, we had a very reasonable number of procedures done when comparing to the previous years. Also, we increased other activities like home hospitalization, decreasing the number of patients in our hospital or that needed to stay inside a hospital, and also providing, for example, medicines for the patients that come to hospital to receive specific medicines that are not available in local pharmacies. So we had a program to send these medicines to the local pharmacy so that the patients did not have to come to hospital just to get their medicines. Next, please. We had, of course, cases of patients that were diagnosed with COVID-19 after being admitted negative or at admission test, and this was a major concern for us. We know that some of these are people that come within the incubation period, and some of them also acquire infection inside the hospital. So we had to work with this. This was a major concern for us. We have to keep our hospitals safe for the patients that come to have because they have other problems and not COVID, and not get COVID inside the hospital. This is very important. So what did we do? Well, all of the different measures, like reducing the people that are inside the building, for example, limiting the visitors, the students, also increasing the physical distancing between patients, and for example, on settings like eating, like meals. Universal use of masks, including all patients and all professionals, was done from the beginning in March. Also looking at any suspect of having COVID through questionnaires of everyone coming inside. And I would stress this important measure, testing. So we started testing all people on admission, even if they are not suspect of COVID back in March. Then in November, we started testing not only on admission, but also at a later time, 5 days after admission, so that people that were during incubation time would be also diagnosed. And later on, we saw that the number of cases was still important, and so we increased the number of testing. We started testing also on this every 5 days, so that we could diagnose very early any case of COVID-19 that was appearing inside the non-COVID areas and remove and isolate these patients and stop the transmission. Next.
I'm sorry,
so
we are
just
really on time.
yeah, it's over. I'm just going to
Great.
say thank you to all of you, and thank you to these people that are the heroes that helped us during all this time. Thank you very much.
Thank you, Dr. Alves. And I will not recap your presentation. It was really interesting. We might have less interaction at the end of the webinar, but it was really interesting, your presentation and your experience from São João. Thank you. Let me turn now, thank you, from Portugal to PR China, to Professor Sunny Yang, who is tonight with us. It's late in Asia, in Northeast Asia. And Professor Sunny Yang is the director of the International Center for Collaborative Research on DRR of the Beijing Normal University in China. Dr. Yang, you have 8 minutes. Thank you.
Thank you very much, Anna. So can you hear me?
Yes, we do.
Thank you. All right, so first I would like to thank the organizers to invite me and providing us a chance to share some of the practices of COVID-19 prevention and control in China. Well, second, I have to confess that I'm not an expert in medical service, but a researcher in disaster risk science. So tonight I would rather to share some perspectives from the emergency management side. Thank you. Next slide. All right, I assume that everybody still remember like 13 months ago when the breaking news about an unknown serious infectious virus was reported in Wuhan. And then the city announced the lockdown on January 23rd, 2020. And Wuhan, well, shown as the blue star on the map, located just right in the central part of China. And it is one of the most important transportation hub of China. It is a city of more than 15 million people, and 5 million people left Wuhan before the city lockdown. So now, next slide. So from a disaster perspective, at that time, we already known that it can be very, very serious. It can be a catastrophe because, from the hazard side, it's a new infectious virus. People have very, very limited knowledge about it. On the exposure side, we have a huge population in Wuhan, a permanent population of 11 million, and a floating population of over 5 million in Wuhan. And also, at the same time, the vulnerability of Wuhan is really high. The whole city has limited healthcare infrastructure. About
We lost connection.
40% population who are 60 years old or older. And at that time, people have very low public awareness about this virus. Overall, we are just unprepared. So, we know that risk is a function of the hazard intensity, exposure, and the vulnerability. So at this time, the risk assessment framework really helped a lot. Next slide. Yeah, but probably all are familiar with the 4 priorities for actions in the Sendai framework for disaster risk reduction. I don't want to read through all this 4, but I just want to say that after 13 months, when we look back, we notice that this framework really worked in China. Next slide. There were a lot of measures in China. I really cannot enumerate all of them, but I want to say that I think the most important feature of the practices in China is it's all governments, all societies approach. And this basically means all different government agencies and all societal stakeholder groups work together, coordinated and tried very hard to fight this pandemic situation. This including the identification of infection source, control the infection source by cutting off the long-range transmission links such as airline, railway, high-speed train to prevent and control the spread. And we started the rapid epidemic investigation and information sharing from January and February last year. To control the transmission, we initialized different city level, community level, family level quarantine plan in early stage. Then later on, we initialized this risk assessment and zoning. And of course, at the same time, we popularized the knowledge of sanitization and epidemic prevention to the public. As for the resource allocation, in very early stage, we had great difficulty in hospital beds and doctor and nurse human resources. But by February 15th, which is about like 1 month's time after the discovery, we newly constructed 50,000 hospital beds in Wuhan, and by February 20th, we constructed 100,000 hospital bed in Wuhan. And also, the government initialized something called a paired assistance program. And more than 40,000 Medicare people merged to Wuhan and Hubei in less than 20 days' time. And these are basically doctors and nurses from other provinces. And of course, here, military forces helped a lot with the construction of temporary medical sites and helped a lot with emergency logistics. Meanwhile, governments and the industries, they invest a lot in research and the development of drugs and vaccines. The different places initialize different special programs to protect the vulnerable population, such as the patients in hospitals, the senior people in nursing house, prison, etc. A lot. But I think the key part is this all governments and all societies approach that really helped us to really work out this model. Next slide. Here, I want to maybe elaborate a little bit more about this risk assessment and zoning program. This is proposed by a national guideline, which is announced by a government level coordination mechanism called Joint Defense Joint Control Mechanism of the State Council. And in this national guideline, it specifically stated that we need scientific prevention and control. We need to have precise policy implementation, and it will encourage regionalization and classification, which means we need dynamic risk zoning and diverse control measures and a different schedule for factory resumption. Here, I just showed 2 examples. Every province has their own dynamic risk assessment system. Here, I showed 1 example from Shandong province and 1 from Yunnan province. So, with this system, different places can really have more in time and precise risk information so that people can better understand their risk. Next slide. Another point I want to introduce a little bit more is about this cross-sectoral collaboration among ministries. In China, according to the emergency response law, we have 4 types of emergencies: natural disaster, workplace incidents, public health incidents, and public security incidents. The first 2 were taken care of by the Ministry of Emergency Management. COVID-19 is a public health incident, which should be taken care of by the National Health Commission, and the last one will be taken care of by the Ministry of Public Security. But in a catastrophe scenario, all these different ministries will work together. Next slide. Here, I want to introduce a little bit more about this, this role of MAM, Ministry of Emergency Management, how they contribute in these practices. Because it is a member institution of the Joint Prevention, Joint Control Mechanism of the State Council. So in this whole process, They helped with this rapid allocation of emergency relief supplies, such as like beds, coats, tents, and they also ensure the safety of makeshift hospitals and designated hospitals. Makeshift hospital, we refer to those temporary medical sites, transferred from a gym, from a convention hall. So in the design stage, MAM will offer suggestions for site selection, structure construction, emergency evacuation plans, etc. And in the operating stage, MAM offers supportive management to ensure safety. At the same time, MAM will help to guarantee the workplace safety of enterprises that produce anti-epidemic materials, and also provides local assistance, such as transporting affected people, transporting anti-epidemic materials, and also disinfecting public venues, even the public area of hospitals. So this type of coordination really improved the efficiency of the system. Next slide, please. Well, there, of course, are lots of efforts, but I just want to say that this data shows the effectiveness of these practices. Here are the cumulative cases of 30 provinces in China's mainland from the last January 1st till now. We probably can see that in China, the epidemic situation was controlled well, especially after April 2020. We can see that the newly confirmed cases are very limited. So with this, I want to conclude my presentation. And I think the two important message I want to bring here is, first, I think the framework of DRR really worked in China. And the second is, I think this all governments, all society approach is the key feature in the practices in China. Thank you.
Thank you, Professor Sani, for sharing your experience, and you really brought the lens of disaster risk reduction in today's webinar. And you was highlighting the dynamic risk zoning, the importance of this dynamic risk zoning and the measures in China. Thank you for sharing the cross-sectoral collaboration from ministries, which is a key message we are taking from your presentation. I'm turning now to our next speaker, who is our WHO speaker, Dr. Dirk Harmans, Program Officer at the Health Services Performance Assessment for the Life Course at WHO headquarters. Dr. Harmans, the floor is yours.
Thank you, Anna. Thank you for this introduction. Good morning, good afternoon, and seemingly good evening for some. My presentation aims to provide you with an overview of the WHO suite of health service capacity assessments in the context of the COVID-19 pandemic, and to explain its rationale, how the suite and the individual modules can be used by countries and by individual facilities to monitor their capacities and identify areas that need improvement. Next slide, please. As we all know, the COVID-19 pandemic has really impacted the functioning of healthcare services. And through the direct impact of COVID-19 cases, and through the indirect impact the pandemic is having on the functioning of health systems and on the society as a whole, such as effects of lockdowns and diminished trust in the safety of facilities. In order to be better prepared and to mitigate these challenges, countries and facilities need accurate and real-time data to allow them to make the necessary decisions. In order to support countries to address this need for accurate and real-time data, WHO has developed this harmonized suite of rapid health service capacity assessments. Important to note is that the development of these modules use the wide consultation process within WHO, as well as with partners such as UNICEF, GFF, World Bank, the Global Fund, Gavi, and the International Hospital Federation. Assessments have been developed based on WHO standards and guidance, prioritizing country needs, while still to be tailored to country contexts. The different assessments look each at specific content areas. They have been developed to complement each other. The assessments can use paper format or digitized tools. The proposed methodology is light, rapid, and safe to use for monitoring in a pandemic environment. Implementing the assessments takes on average between 30 and 60 minutes. Assessment findings are to be disseminated near to real time with decision makers to inform the making and taking of practical, time-sensitive decisions and actions. Target users can be hospital managers, national or subnational health authorities, or incident management teams. Depending at which level, mitigation actions can include resource reallocations, revision of health service strategies, such as deciding to maintain only a limited range of priority services, or investment plans. Next. This table gives you an overview of the different assessment modules in the suite. Presently, the suite includes 7 modules. The first 4 in the table are the core modules. They are the Rapid Hospital Readiness Checklist, the COVID-19 Management Capacities Assessment, the Continuity of Essential Health Services Assessment, and the Community Needs Perception and Demand Assessment. The bottom 3 are modules for in-depth assessments, and this in the specific areas of medical oxygen administration, COVID-19 safe environment measures, and the facility IPC situation. Findings from the core assessments may inform the need for these deep dive assessments. 2 modules, the Continuity of Essential Health Services Assessment and the Community Assessment, focus mainly on the maintenance of essential health services. The other 5 focus on COVID-19 case management capacities. With the next slides, I will give you a very quick high-level tour of the 7 modules. Given time constraints, I will probably need to skip some slides. The Rapid Hospital Readiness Checklist allows to assess overall hospital readiness and hence to identify priority actions to prepare for, be ready for, and respond to COVID-19. As its name indicates, the assessment focuses on hospitals. The instruments automatically calculate scores for 12 different domains. Next. During the first webinar in this series, 3 weeks ago, we were very lucky to hear the story of the Hope Foundation for Women and Children, which runs a hospital for Rohingya refugees in Bangladesh. Dr. Mahmoud shared the findings and their experience of using the checklist. They found the checklist easy to use and very helpful for the development of their improvement plans. Next. The COVID-19 Case Management Capacity Assessment focuses on hospitals which are responsible for managing COVID-19 patients. It allows to assess present capacities and surge capacities, numbers of beds, oxygen supplies, staff affected with COVID-19, IPC measures, availability of PPE, diagnostics and therapeutics. It is used for national monitoring based on a sentinel sample of hospitals. Next slide. Kenya implemented a first monitoring round using this COVID-19 case management capacities module, as well as the 2 other core modules, continuity of essential health services and the community assessment. Dr. Helen Kiari from the Ministry of Health presented the Kenya findings at the previous webinar. What you see here is an extract from the automated dashboard, which provides data and graphics on key indicators for a sentinel sample of facilities across the country. PPE supplies, was clearly an area that needed strengthening. Next slide, please. The continuity of essential health services assessment can be used for primary care facilities and hospitals. It allows to track and monitor the maintenance of essential health services across several areas such as health worker capacities, staff infections, changes in utilization, reasons for disruptions, IPC measures, availability of PPE, diagnostics and therapeutics, and COVID-19 vaccine readiness. It is also meant for national monitoring using a sentinel sample of hospitals and primary care facilities. Next slide, and next. The community assessment is another core module, and it looks at the health services from the demand side perspective. What are the service needs? How is safety perceived? Is there a lot of vaccine hesitancy in the community? It is based on interviews with community key informants, such as community health workers or community leaders. Next, and next. Next. The biomedical equipment for COVID-19 case management inventory is to be used in hospitals and COVID-19 treatment centers. This is an in-depth facility inventory focusing on equipment and supplies for oxygen administration and ventilation. Next. The assessment module ensuring a safe environment for patients and staff in COVID-19 healthcare facilities allows to assess structural capacities and administrative controls to protect the health and well-being of both patients and staff, and this in hospitals dealing with COVID-19. Next and next. And last but not least, the assessment, infection prevention and control healthcare facilities response for COVID-19. This is a crucial module to assess IPC capacities of hospitals dealing with COVID-19 cases. It looks at presence of IPC focal points, supplies, guidelines, training, and patient and visitors flows. Next. Coming to an end, I will not be able to go into the details of this interesting but rather complex slide, which we borrowed from the WHO Euro office. This diagram demonstrates how countries can use these assessments to inform the development of their mitigation strategies and actions during the pandemic, but also for their long-term plans like the national strategic plans for emergencies and disasters, and for their monitoring. Next, please. I hope my presentation gave you a good first taste of what this suite of assessments is about and initiated your interest for using these assessments in your facilities and countries. Thank you for attention. Back to you, Anna.
Thank you, Dr. Horemans, for your very interesting presentation and all of this health service capacity assessment in the context of the COVID-19 pandemic. Very important assessment for community assessment, and thank you very much for providing this guidance to participants. Let me, we have very few minutes, so I just select one question, which I will direct to Dr. Adhikari. Dr. Adhikari, could you describe briefly the coordination that takes place between the Ministry of Health, ADCs, with the disaster management or EOCs from the national to local levels? Over to you, Dr. Adhikari.
Thank you, Anna. Actually, we have the hospitals in local levels. These hospitals might be small or bigger. And we have created the network in between the big and small hospitals to have the hub and satellite networks. And if there is any disasters or any such infectious hazard or such pandemic situations, each satellite hospital are mandatory to report their hub hospitals, and the hub hospitals are mandatory to report to the local level and the district health offices. And these district health offices mandatorily to report to the provincial health emergency centers. And all health emergency centers are interlinked with the national health emergency centers. So they are interlinked like this in this network.
Thank you very much.
Now over to you.
Thank you, Dr. Adhikari. All speakers and my colleagues have responded to the questions in the webinar. Any pending question will be sent to you, and we will post in the event page. Let me close the webinar with some passing the floor to our closing remarks representative, Ms. Sara Perazzi, from Partnerships and Program Manager of the International Hospital Federation, who is a co-organizer of the COVID-19 Safe Hospital webinar series. Ms. Perazzi, the floor is yours.
Thank you so much, Anna. So we have now reached the end of this webinar, and the fact that almost 200 participants joined and actively participate to this event underscores the importance of the issue we have raised today and the need for effective exchanges. We heard about the experience and good practices from hospitals that they have put in place and as an integral part of national strategic plans for emergencies and disaster from all hazards. And we also had the opportunity to learn more about the WHO technical guidance in providing uninterrupted essential health functions and in the context of COVID-19 pandemic. Exchanges with the audience were very dynamic, and it emerged that the alignment of national strategy with public health and hospitals seems to remain very important and critical. I would like to thank all the speakers today. Certainly, we have all learned a lot from your experiences and achievements in managing and controlling the COVID-19 pandemics. Your practical experience shared with us are informative, and the reflections are important in enhancing the strategic preparedness and response to this pandemic, as well as other potential emergency and disaster that may arise in the future. So strengthening the safety of health facilities is paramount. It is also a salient reminder of the need to engage all sectors under the highest potential leadership and to adopt a holistic emergency preparedness and response program, including safe hospitals. I would also like to thank our webinar organizers, colleagues and friends from the UN Office for Disaster Risk Reduction, and our colleagues from the WHO and the International Hospital Federation, which I represent today. The IHF, the UNDRR, and the WHO, of course, the rest of the UN community are united in supporting countries across the world during this pandemic. We are all in this together, and as our collective action is needed to stop the COVID-19 chain of transmission, doing whatever it takes to bring the pandemic to an end and making the world safer. I thank you all very much, and I wish you to stay safe and healthy. Anna, back to you.
Thank you, Sarah. We have successfully concluded the second session in the COVID-19 Safe Hospital webinar series. Thank you very much once again to our panel speakers, opening and closing remarks speakers, and all participants, all of you. Thank you from around the world to join us in this webinar series. See you in the next webinar, which is scheduled next month on 18 March. Thank you very much, and good night, or good day.
Bye, Anna. Thank you very much.